Good afternoon, everyone. I want to really welcome you to this extremely important and extremely timely discussions. Thank you all for joining. It's no secret that this past year has put a spotlight on access to health. As the CEO of the Global Health Alliance, this subject of equity in healthcare access is actually one of our four fundamental pillars. And I am exceptionally privileged to have the group of speakers and to have all of you in attendance for what I think will be a fascinating discussions. The COVID pandemic has put a spotlight on the issues of access to health and equity in that access to health. This has been seen in many, many areas, from vaccine access to treatment and care. But of course, the issues that were put in focus by the pandemic are really only a very small part of what has been a fairly systemic lack of equity and access in healthcare systems, and not just overseas, but very much in the US and in the developed world. So this is an issue that spans many countries, many healthcare systems, and many of our collective work overseas as well as at home. The inequity results in health disparities. For example, infant mortality for Black babies being nearly 2.5 times higher than for white babies, or diabetes rates that are more than 30% higher among Native Americans and Latinos than among whites. These inequities are not just ethical and moral issues. Studies are increasingly showing that there are economic consequences in the delivery of healthcare due to these inequities. An analysis recently by the Joint Center for Political and Economic Studies in Johns Hopkins University explored the economic burden of health inequities in the US and revealed that there are significant financial burdens and that the elimination of health inequities for minorities could reduce total healthcare costs by as much as $1.5 trillion over a 3-year period. Now, that's why we're here today. We're going to try to discuss the urgent need for improving equitable access to health and what each one of us can, on a very practical basis, do with our organizations and individually in trying to improve equitable access for everyone. We hope you walk away today with some tangible ideas and some new knowledge that perhaps you can incorporate in your own work going forward. As your moderator today, I am honored to be introducing you to our speakers. We will be hearing from Dr. Ahmed Ali, who is the founder and executive director of the Somali Health Board, as well as a clinical instructor at the University of Washington Department of Global Health. He's also the co-owner of the Othello Station Pharmacy in the Rainier Valley areas of Seattle. Mariam Zameer, who is the team lead for health systems at VillageReach, which is a nonprofit global health innovator that is focused on transforming healthcare delivery to reach everyone. These speakers represent different perspectives on this topic of equitable access to health. And we're looking forward to hearing their perspective on equity and equality in access to healthcare from different areas of focus, internationally, nationally, locally, community level, healthcare system strengthening perspective. So to start our discussion, I think it's very important to maybe arrive at some suggested definition of what equity and access to health actually means. Mariam, maybe we can start with you. Can you share your thoughts about the definition of equitable access to health? What kind of things should we consider when approaching this topic?
Thanks a lot, Maurizio. Thanks WGHA for organizing this extremely relevant and interesting discussion, which I'm really looking forward to. When we talk about equity in healthcare, it really is the equal portion means, everyone has the same facilities and everyone has the same background and circumstances, and we're giving them the same sort of access to healthcare. So an example of this might be that health facilities are all open 9 to 5, and anyone can get access to the healthcare between those hours, or a certain service is available for $10, and anyone who pays $10 is able to get it, and that's equal access for it. And sometimes we focus on equal access, but I really think what's important to consider is what is equitable access for healthcare. And that considers sort of the different socioeconomic background, gender, culture, race, et cetera, that comes into play when we are talking access to healthcare. So those dollars to access a healthcare service might mean nothing for somebody, but it might mean an entire person's food for one day. Similarly, the 9 to 5 schedule may fit for a lot of people, but depending on the work that you're doing, the transportation that you take, the community that you're coming from, the gender that you are, can impact whether you can access those healthcare services or not. So I almost feel like equity nowadays has become a buzzword, which a lot of programs and projects use without thinking about what do we mean by equity and how can we define equity. It's sort of, we just insert the word and continue in our regular programming anyway. And one of the things I want people to sort of think about and consider is to step back and think about this in a 4-step way. The first being, let's identify who the people are, where are they, who are they? Think about the very specific challenges that they would have to go through and that they might be facing, and they would be different for different types of communities. And then think about sort of the strategies that you can use to improve their access to healthcare, mitigate those challenges, as well as improve and measure if that equity is improving or not.
And Ahmed, and obviously Mariam, jump in as well. One interesting question that comes up when you start thinking about both this definition of equity and equitable access is, how would you measure that? How would you know that you're sort of on the right track? And the old adage that you can't improve things that you can't measure. Is there some practical implementation, for example, that you guys use with your community within the Somali Health Board to sort of indicate to you whether you're reaching your stated goals? And Mariam, I'm sure you have experienced that same issue as part of your work overseas. So just interested in your respective perspective on measuring and achieving progress in these subjects.
Thank you, Maurizio, and good afternoon, everybody. Thanks to WGHA for coordinating this forum. And it's an honor to serve this panel discussion with Mariam. I think continuing where Mariam left on the definition itself, it's a matter of figuring out at this point, even when we look at very closely, let's examine King County where we are, and we look at, one of the largest and the most what's considered progressive counties across the country. But when you clearly look at the map itself, you do notice that North King County oftentimes have much more resources when you look at social determinants of health in compared to South King County. And I think that in itself should be able to put a clear picture in terms of how the disparity exists within certain demographics, because South King County is predominantly where immigrant, refugee, BIPOC, Black, Indigenous people of color reside, compared more or less when you look at North King County. Now, when we examine in terms of how do we measure inequities, or what type of tools do we utilize through Somali Health Board's efforts as a grassroots organization, some of the things that we have actually been able to identify early on is to determine who is serving these communities and what type of platform should we include to make sure that when we're talking about, for instance, accessibility to the healthcare system itself, do we have enough providers that look like the communities that we're speaking of? Do we have enough nurses, medical assistants, doctors that actually speak the language, understand the cultural barriers, sometimes even the religious barriers that are exacerbated by the health inequities that we're speaking of. So I think that one of the measures that I think one of the tools that we can utilize is to ensure that those communities are empowered enough to make sure that they have professionals that reflect those populations as well. I think that is something that as an organization, we put a lot of effort into. And I think that can also be translated across the globe as well, is to empowering the communities that you are serving. And I also think the other measure that you can indicate from a policy perspective is to make sure that those communities actually they're able to sit at the decision-making tables. They are able to sit at those spaces where those discussions are taking place. And, I think we can measure chronic diseases in terms of numbers. We can measure how many folks are impacted by diabetes, but when we're actually implementing those policies in a way that is not reflective of those communities, I think we're just sort of like kicking the can down the road. I think there are multiple ways to measure those things, but as an organization, I think the biggest impact that we've had, particularly right now, working along with other ethnic health boards that we helped establish, is to figure out how do we ensure that when we're speaking of social determinants of health, our communities, the folks that we're serving are actually adequately included in those decision-making processes.
Terrific, Mariam. Any perspective from your and VillageReach's experience?
Yeah, so I think there are different ways to do this, and depends on what you are trying to measure. But as an example of this might be that you are realizing that people in certain communities are not getting vaccinated, and one of the reasons they might not be getting vaccinated is because there's no supply there, and they have constant stockouts for this. And so then you need to sort of dig deeper into this and say, but why are they having stockouts? The reason for stockouts or supply chain interruptions are very, very different in different parts of the world, in different regions, and there's a multi-layered challenge and issue. And one of the challenges can be that actually the vaccinator doesn't have money to go and pick up stock, simply that, or the road got flooded, and so that there is no way to actually go and get the vaccine, or the transport that was supposed to come is being routed somewhere else to do some other work, and they're not being used to deliver the vaccines or any other products that they're using. So there can be different challenges. And so I think focusing on what is it that the problem that you're trying to solve, and then measure based on that is important. So for example, if you're trying to say, okay, the vaccinator did not have money to go and pick up the stock from the district or the place where or the warehouse, you can then try and improve that by making sure that they're actually getting the money or improving the financial systems. And then you would set certain indicators to say, okay, how many stockouts were there, or did the money actually get to the pockets of the vaccinators in time, and do this continuous monitoring and measurement on a continuous basis to see if there's actual improvement. So you can do it at a higher health system level, but then you can also do it at a more operational level to see if the specific challenges that you're trying to solve are actually getting solved.
Terrific. I am fascinated by a thought that you both shared in your respective work with me that really dovetails on some of this question and some of the comments you were making, Ahmed. And this is the question that almost by definition, the communities that are being excluded in equal access to care are also communities. And there is the very important business of building trust with those communities. And to some extent, I'm wondering what your thoughts are. First of all, how do you build trust with a community? And I'm really interested in that, in your experience within the sort of Somali community, immigrant community that you're addressing. But more importantly, whether you think the building of trust plays a role in the ability to then have that community seek the access to care that may be available to them, but may not be necessarily part of that culture or that sort of ecosystem. So, could you speak to the issue of building trust and your thoughts? And also, I know that obviously you had the effort with the Somali Health Board, but you also have this sort of microcosm in being a pharmacy in one of these communities, and sort of, what are the sort of differences between that very local type of approach and perhaps the more sort of institutionally programmatic approach that you might have at the level of the Health Board?
Yes, absolutely. I think that's a very good question. When you look at different aspects, whether it's the pharmacy aspect of the work that I do, and from the clinical perspective, and early on in my career, I love being a pharmacist. I enjoy my the one-on-one interactions with patients, but I also found myself limited to the four walls of the pharmacy. So knowing that I can have an individual impact on a case-by-case basis, and I, with that aspect, it made me realize that I could do more from a public health perspective by sharing some of the lived experiences with the larger system, but at the same time empowering the community from a larger scale. And I mean, when I say this, I'm referring to the understanding of how we created Somali Health Board in the aspect of making sure that the community that we're currently serving, the Somali population to be precise, the East African community, their perceptions and understanding how medicine is delivered is drastically different when they're in East Africa and Somalia compared to here in the United States. To a certain extent, the concept even of chronic disease management is extremely foreign for people to go and get their diabetes checked, cholesterol checked on a regular basis. Folks used to go to the clinic or the hospital only when they're sick. But when you come here, there's a different aspect of how we really want people to live their life. And in order for us to even deal with those disparities that are impacting collectively the community. So having a trusted messengers, people that actually folks understand and they can relate to, I think is the biggest aspect of building trust. I think we also sort of changed the narrative within King County through the Health Board Coalition, this model itself that, communities of color, BIPOC communities actually do have healthcare professionals that are actually integrated within the community. They do work as healthcare professionals, but they also live in those communities. And that's the essential aspect of the Health Board model that we created, whereby we have doctors and nurses and pharmacists that represent those communities that are going to those communities on a regular basis, whether it's an event or the mosque or the churches, at the same time understand how the system works. And that's where I think even if you were to, let's say, create a certain type of trusted messengers that, the system creates people that, as community health workers, it's not the same as when you have a medical health professional that speaks the language, that understands the language, the culture, the religion, but at the same time practices that field as well. I think the overall arching aspect of the building the trust itself comes not just with knowledge, but also the lived experiences from those healthcare professionals as well. I think when you look at a global perspective, I think the most important thing from what I have seen, even working in Somalia to a certain extent, is community participation itself. I think there are two factors I think that should be important when delivering let's say global effort, and that includes community participation, making sure that the people who are actually serving buy that thought process and are involved into that thought process. I've seen NGOs go into certain communities and implement certain type of work, and then years down the road there's no actual outcome that is measurable and useful to those communities. You also need the political willingness for that intervention itself, for you to achieve what you need to achieve when you're talking about global aspect or even locally. I'll give you a very good example. We had years ago when we started Somali Health Board, we did have an issue with one of the hospitals where Somali women who are pregnant were having issues with regards to sort of, according to them, felt like it was being pushed into getting C-section during their pregnancy period. So what we did was we had an intervention where we held focus group sessions with our nurses and discussed what the issue was, why some of them were hesitant to go into their doctors up to the last stage of their pregnancy, which was very much concerning to us. And what turned out, what we realized was through those discussions is that it was new mothers who immigrated here or moved here as refugees, and they didn't have the same support system as they did back home, where you have their grandmother, you've got the mother, you have the sisters, older sisters, or even entire village that was out there to help the new mother go through the gestational period. Here, it's just her and a husband, and then a very foreign healthcare system where you're being told to do so many things during your pregnancy. And at the end, you're told, well, you got to go through C-section. So in order to make sure that the mother and the babies are healthy and for a legitimate C-section has to take place for both the mother's and the child's health, we intervened and created a program called Centering Pregnancy and worked along with neighbor care clinics. We also work with Swedish and others as well. This is being implemented across 3 other health clinics across South King County at this point. And that's become one of the most useful programs for those mothers, get to know one another. It's a cohort-based model. And that clearly indicated that the trust level that we built with them, that they understood that these are health professionals that speak their language, that understand their culture, and for the system to take on that as well, made it easy for them to go through their pregnancy period in a much less difficult process than it was before.
Fantastic. And Mariam, maybe as you jump into this conversation, I would love to also hear your thoughts about, from a practical perspective, how far should a healthcare provider go in partnering with non-traditional influencers, and what is the role of those non-traditional influencers in this sort of trust building with these targeted communities?
Yeah, absolutely. What Ahmed was describing made me think of an incident that just happened, I think, a couple of weeks ago. My mother is a pediatrician in Pakistan, and she used to see a mother about 25 years ago when the mother's kids were very little. And when the COVID vaccine came out, she tracked down my mother 25 years later to ask if her son, who's now going to college, should get the vaccine. And I thought it was very amusing because, it's my mother, it's not a pediatric vaccine. She's not an infectious disease specialist. She doesn't even see that mother anymore. She saw her 25 years ago. She's the mother is not an anti-vaxxer because she got all her childhood vaccinations for all her children. But she called my mother up to ask, can I actually get this vaccine for my child who's now 24, 25, and is this going to impact his fertility? And I thought this was a very interesting incident because it, I think, goes back to this element of trust and who are your trusted providers and who do you trust to provide you the correct information. I think sometimes we believe when we are doing this work that, if you just provide that correct information, if you just bombard them with that right poster or that right, nice graphic, people are going to know what that's the correct information, and they're not going to believe things around bioterrorism or people who are going to put chips in them when they're going to get vaccinated. And I think that's just a flaw in the way we think about this and the way we in our approach, because it's not lack of access to information that is causing this. In some ways, it is the increased access to information. You can get information from anywhere. It's about the trust of the source of the information who is going to be providing this. And we have to step back and think, who do people trust and where are they getting trust from, and who do they rely on for correct information? And this impacts the way we do global health as well, because we think, we need to work only through traditional public health service providers. And I think it's an interesting model, which doesn't reflect the reality in a lot of countries, especially in underreached and underserved populations. When I think about a lot of urban poor populations, there's so many studies out there, like 60% of health services in Nigeria are provided by private providers. It's about 40% 5% in Liberia, close to 80% in Pakistan. And we're still so focused on, improving and focusing on the public health system and not thinking about who are people going to for healthcare access and delivery. And they're going to these private health providers who can be your neighborhood doctor, they can be your, community nurse, they can be a for-profit provider, it can be a nonprofit provider, it can be a faith-based organization, but they're going there because they trust them. And sometimes they're willing to pay out of pocket, not always, but sometimes they are willing to pay out of pocket because of this perception of quality and trust. And so when we're thinking about improving healthcare access, we have to think about how can we help governments to actually work with these private providers and contract with these trusted sources of information instead of trying to create a parallel system and saying, okay, let's keep working on this public health system, which is maybe not where people are going to access their healthcare. The other thing when I think about trust is, this lack of trust between countries and the politics behind this. And I think COVID is a great example of this. So when the COVID-19 vaccine came out, the solution from COVAX was that we're going to give everyone AstraZeneca, which was a decent, good solution at that time. However, Europe decided we're not going to give AstraZeneca to our population for whatever reasons. But we were still continuing to say all low middle income countries will get AstraZeneca, but people were not going to get it. And I think instead of, again, bombarding them with like more and more information, we have to understand why they were thinking about this. Why should they think that they need to get a vaccine which is being rejected by Europe? Why should I get it at all? And then the high efficacy vaccines are being reserved for high income countries. And that is also not a completely unfounded reality, there is also truth behind that, because high income countries did hoard vaccines and they did hoard the mRNA vaccines as well. And then sort of this colonial history of medicine that there is as well. There is a history of experimenting on people of color, giving them untrusted drugs, et cetera, all of that. And so I think there is a reason, rationale to why people think this way. And so this element of like, who is the source of information is more important than providing more and more information to people.
Terrific. So
Maurizio,
I wanted to, please, Ahmed.
Maurizio, you can just jump in onto what Mariam has actually mentioned when it comes to the global access of the vaccine itself. I think one thing we really need to remember, especially for anyone who probably is listening that is in a position to make decisions about these things, is that if everybody around the world is not safe, none of us are actually going to be safe, particularly now with the COVID, the pandemic. And the notion or the thought process that we have here in the West, particularly in the United States, that we're always getting the best of everything, and secondary is the rest of the world, or we will export whatever is left over. I think that is just going to continuously exacerbate right now the current pandemic that we're facing. As a pharmacist, and rightfully so, we're going through different processes of the vaccine access. Oftentimes I cringe when we're disposing almost a full bottle of the COVID vaccine because we only gave the vaccine to only one individual, and we won't be able to use the rest of it, when I know the rest of the world is continuously suffering at this point. I think I overheard the NPR just this week that probably 5 or 6% of the entire population of the African continent is currently vaccinated, which is just mind-boggling to a certain extent, right? But going back into the non-traditional influences, I think for us as an organization, as I mentioned, trusted messengers, a lot of times it doesn't have to be actual healthcare providers. As an organization, we've actually utilized some of our community members, particularly in terms of, getting folks together when before COVID times, when it comes to either the health fair events that we had attracting about 1,000 people. There are some community members who are actually well respected. They're not healthcare professionals, but they're trusted. They are respected, and we would use some of those in terms of our media coverage in some to extent. And now we even maintain a weekly COVID conversations since the beginning of the pandemic that is streamlined on our Facebook and Zoom on a weekly basis, in which one of the participants of three folks, a healthcare professional, a community member, and the imam of the mosque. So we alternate different imams, simply because we know, as a healthcare professional, I think I can influence enough people, but there are people who will be listening and will follow the imam's decision-making process to a certain extent. And then I think that is something that worth looking at when we're talking about, non-traditional influence when it comes to the health decision-making process.
Yeah. And I just want to also bring in the role that community health workers sometimes play in global health. And, we think about them as only mobilizers or bringing information, but depending on the structure that there is in that community, they live in those communities. And sometimes they are sort of a trusted source of health information for them. And I think just around the world, community health workers are often this like volunteer, unpaid service in many, many countries, and they keep getting more and more workload. But how can you sort of give them more of leverage and more highlight their role in terms of communicating some of these messages and working with the communities and using the bridge that they have and the communication channels that they have to understand their concerns of the communities and also answer some of those concerns in the communities. So one of the things that has come out from at least the COVID pandemic is that there is a little bit more discussion around what is the role of community health workers and how can we formalize them as a health workforce? Is it possible that they can actually provide immunizations as well? And they do already in some countries, but in many countries, they're only social mobilizers. But how can we sort of think about expanding their role, but then also paying them for the work that they do and formalizing the work that they do a little bit more?
And Mariam, to that point, and Ahmed, please jump in as well. As we think about the reality on the ground in the US and we look at our underserviced population, including in the context of our regulatory and liability landscape, do you think there is space for community health workers type of role aimed at specific communities? Ahmed, you had mentioned to me that sometimes as healthcare providers in this country, we need to have greater humility in approaching the patient, and that the sort of doctor-patient or provider-patient relationship is not necessarily based on the same trust factors. Is a community health worker something that our providers that may be listening in today should consider sort of developing to reach some of these communities?
Maurizio, yes and no. And I stand very firmly when it comes to the community health worker model. It's a successful model. It works really well. I know it's very useful. And we do have community health workers within the Somali Health Board as an organization. However, on the other hand, I am a very pragmatic person when it comes to reducing disparities and long-term objectives. And I know, and I have talked about this on so many occasions, that I think the main focus we need to put on is to actually develop the next generation of community of health professionals in general, practitioners that reflect and look like the communities that the clinics and the hospitals are serving. What I am afraid of is actually the thought process of large hospitals and clinics putting a lot of funds and efforts into developing community health worker model, yet at the same time neglecting, young health professionals or even high schools and college students who are ambitious enough to pursue different careers, whether doctors and nurses, and not give them those platforms as well. There isn't a shortage of young folks who are interested, particularly communities of color interested in the health field. It's just that they don't have access. As an organization, we've been able to put about 5 or 6 of them through medical school, about 10 through the pharmacy school, all of them through mentorship that we have garnered through our organization. And I know before that it was very difficult. Some of the hospitals and clinics where we reach out to were putting such huge barriers in these young folks, a high schooler who's being told, hey, you have to be able to provide all your medical records and your immunization records who at the beginning did not even have someone that can mentor them. And when they do find that opportunity, they're sort of like given the runaround that I've seen to a point whereby it just, we have to kind of intervene ourselves, and our own health professionals have to sort of utilize their own spaces to empower and mentor those youth. So I want the, you know, the clinics and the hospital that are serving, particularly across anywhere in the United States, to be able to mentor these youth that are interested in and reduce the barriers that they're oftentimes experiencing. I talk about my own experience. I remember when I wanted to go to pharmacy school, I did not have a whole lot of experience in the field itself, but I was very much passionate about it. I remember walking into one of the chain pharmacies and asking to shadow, and I was told I couldn't do it. But it took a whole lot of, I don't give up easily, but it took a lot of effort to different spaces for me to go get that experience. So I can relate to that. I really don't want to undermine the healthcare model, but I want the large health system to put a lot of effort into empowering Black and brown kids to become other healthcare professionals as well.
And I want to expand on that, because I think this extends even beyond sort of the healthcare service delivery model to like the way global health generally works, right? I mean, you have a lot of projects and programs, et cetera, that are centered in US and Europe, and a lot of decision makers are sitting over there. And a lot of them are white men. Some women, but a lot of them are white men who are sort of sitting there and making decisions and designing programs, and they're not reflecting the reality of the communities and people that are based there. And this goes, I think, to what Emma was saying, like, how do we make sure that there is diversity in some of the way, not just in healthcare service delivery, but in terms of also designing of health systems, and have people of color, have women participating in some of these discussions. And in this, there is a close linkage with, just the way where decisions are happening, where these discussions are happening as well. So now, of course, when some of these global meetings happen, they'll say, okay, yes, of course, we're going to invite people from countries to come in and, be part of these discussions. And not realizing, like, you want to potentially have people participate in these discussions, but you're still going to have your meeting in Geneva, which is it's so hard for most people from low middle income countries to get to. I don't know how many people in the audience have ever applied for a European Schengen visa ever, but it is one of the hardest things to do, and it takes months and months to do. So you can't just be like, I'm scheduling a meeting in 2 weeks, come on over. Money, of course, aside, and transport, et cetera, aside, but there are these like logistic challenges. Like, if you really want to do it, then go there, talk to people, work with those communities, and make them part of the decision-making process as well. And you see this in global health all the time. I remember there was a conference in 2019 in Vancouver for Women Deliver, biggest MNCH type, RMNCH conference that happens every couple of years. And guess what? It was right on the days of Eid in that. And of course, like, nobody in that planning committee was aware that this is a event that is celebrated by about 20-25% of the world. And a lot of them are from your low middle income countries, and they were just not part of the planning committee. So they decided to hold this conference. By the time they advertised it, by the time like somebody probably pointed it out to them, it was too late, and they were not willing to like go through the effort of redoing that entire conference for it. So it's one thing to say, yes, we want diversity, we want inclusion, we want to have people of color being there, but you're not creating the operational mechanisms to do this. Even now, in global health, there are very few to no organizations who will do any kinds of visa sponsorships or who will do any kind of hiring in a new country. And it's for logistical reasons that you won't do it. So I understand why you're not doing it, but then you can't have people from those communities, those countries, et cetera, who can then be part of the discussions, who can design equitable programs, understanding what the needs of the communities are.
So as I hear both of you speak about this need to mentor and educate, community, members of the community to be, quote, mainstream clinicians and providers, so that that trust factor can be built, I can't help thinking that we have some major universities in our audience today, and I'm hearing that, and maybe I'm, amplify or correct me if it's not what you meant. But I think there's probably a role in addressing this sort of inequities in healthcare if the universities, if the medical schools were to also prioritize non-traditional communities in their training program and perhaps provide that role of mentoring. Any thoughts about that?
Yes, absolutely. I think it's really, really important. I know that a lot of the universities do have certain committees or even certain protocols in place to make sure that they implement the diversity into their programs. But at the same time, I don't see a whole lot of efforts that's coming from the major universities here within our state here, to be precise. I think it's vitally important that they have to hire the right people to make sure that that is they are recruiting students, that they are following students into the urban, into the cities that predominantly communities of color live. It's also important that they reach out to the counselors that actually whether it's high school or colleges, and make the effort to include some of the students to apply for those programs. I think while at that notion of the institutions having that ability and the capacity to do so, I also think they should not be in a position. They should also not be in a position to dictate certain things, especially if the community decides to follow certain types of provisions in place. And I'll give a good example. 3-4 years ago, because of the large number of immigrant refugee communities in King County, and a lot of healthcare professionals who are displaced from different parts of the world that immigrated here in Washington State. Somali Health Board, realized there were over 100 international medical graduate doctors that were here, and majority of them were either physicians or even specialized providers in their former countries where they came from. And when they moved here, a lot of them are either doing odd jobs or working as interpreters or translators at the hospitals or clinics. You can imagine the manpower and the amount of brain that is wasted, especially in the time when we know there's a huge shortage of providers in Washington State to a certain extent. So we embarked on this effort to create, after realizing that many of the clinics and hospitals were not actually allowing residency programs for foreign graduates. And I say not allowing because I was actually involved this directly, where some of the clinics were telling and the hospitals were telling us, we don't actually take those kind of people. We're only taking folks who are graduate from medical schools in the United States. They have every right to do so, but at the same time, this is the type of institutional and structural racism that we know continuously impact and create disparities within our communities. So we created this effort to come up with a bill that was co-sponsored by some of our elected officials, took it all the way to Olympia, advocated for that, passed in both houses of the chambers. But before that, we've actually got a huge pushback from the two institutions that have medical schools here in Washington State, that this is not a top priority for them. And there were a lot of financial aspects of decisions that were being made based on why we wanted to have this residency program for these foreign international medical graduates. It's not like we were asking for these folks to be given licenseship to practice medicine. It was just giving them an equal opportunity for them to apply for the residency program so they can practice in 3 years before they sit down for the board's exam and become physicians, if they're able to go through that process, because some of them were. But the good news about this is we didn't give up. We went all the way to a point whereby it was signed by the governor and became a law in the state of Washington that someone should not be discriminated based on where they got their medical degree, and they should be given those opportunities. But you can imagine before 2019, how many of those talents and healthcare professionals that we have lost, and probably driving Uber and doing other odd jobs. Uber, for some people, it's a great career. It pays well for families, but you're asking a healthcare professional to do all odd jobs simply because you do not want to implement certain policies in place. That's the international medical graduate aspect of the battle that we had to go through in order to make sure that those folks have access to the residency program. There are about 5 or 6 of them who have been able to get into the residency program here in the state of Washington. Who spend considerable amount of years, 6-7 years, pursuing that dream, and now have a few more years before they become board certified physicians. And I know for a fact that would actually have a huge impact in addressing the disparities all across the state of Washington. But going back into the large institutions, I think they need to put a lot of resources into communities of color, BIPOC communities, to make sure that they adequately are getting into those programs within their school system.
I want to also sort of go back to this. Sorry, I was just going to say this point of, when we started the discussion around equality and equity in this, right? And so when we have people of color coming in, or refugees or migrants coming in who have this sort of a background, the kind of mentorship or the kind of guidance that they might need is very different. So it's not helpful to have like a blanket mentorship program for everybody, because the system and to navigate the system here is just very, very different, just like it is in every other country. And I know I felt that when I migrated initially, in terms of how do you get a job here? How do you enter a system? And it's just very different. I had never done an informational interview before. I had never talked to people before, like done cold calling before. It's also not very culturally acceptable to do that, just cold call people and do that. But you kind of have to change everything, and so the guidance that might be needed is very different as well.
Yeah, and back to that concept of cultural humility, you both shared with me stories about, especially say with immigrant populations that are used to having a different relationship with a provider. Versus the sort of expected patient advocacy that a patient is supposed to do themselves in connection with a relationship with a U.S. provider, typically, right? I'm reminded of my mother, who's also an immigrant in this country, and every time I would ask her to ask a question to the doctor, she would basically be freaking out and saying, no, the doctor told me to do this. I'm not going to question him. He's the doctor. And so I wonder if part of the sort of mentorship training, in addition to the diversity and being members of the community, should also include teaching all doctors and all providers how to deal with and how to spot cultural diversity and understand how to perhaps communicate with their patients in different ways if they're members of certain communities. Any thoughts on that? Or perhaps even should providers be thinking in terms of having patient advocates that understand that sort of cultural biases as part of their delivery?
Yeah, I do think that's important. I don't know how you operationalize that with all providers knowing about all cultures and all different backgrounds and all hesitations. And I do think one of the solutions is to have a more diverse pool of providers, and going back to what Ahmed was saying as well, and who understand what that language is, what that conversation is. And there are elements of race in this, there's elements of ethnicity, culture, gender as well. I've spoken to several women who, being people of color, when they've gone to doctors, being pregnant to deliver their babies, they've never asked the doctor a single question in terms of, is this something which I should do? What should I do? They expecting answers from the doctor, because that's just how, that's how the health system works in some countries, where you go to a doctor, the doctor tells you to do something and you just go ahead and do it. You don't question it, you don't ask for it, but then at the end of the day, what you're going to get is a big fat bill from the insurance. And this has happened to me as well, where the insurance company will then say and be like, but why did you do it? You should have questioned the doctor. You should have asked what the CPT code is before agreeing, and you should have checked your exact insurance coverage and details to know what is being covered before agreeing to do it. Versus for the doctor, it's sort of like, yes, here, go get a B12 test. And you're like, sure, I'm going to get a B12 test, not knowing whether I'm going to get hit by like $1,000, $2,000 eventually. And that kind of like not knowing how the healthcare system works is different. But I also think there's a resistance from healthcare providers to do it, because after I learned that, now every time I go to the doctor and ask for CPT codes, I feel like they're trying to avoid me because they also don't know what the CPT codes are. The healthcare system in the US is so messed up. The doctor has some idea what the codes are that they're going to be in charge, but actually there's this back-end system where somebody is just going to read the doctor's notes and figure out what those codes are, and then they're going to bill the insurance. You can see the patient needs to be an advocate for themselves, but they actually have very, very little control over this process of how to do it. So you do need a little bit more hand-holding, and I would say you might need this for migrants, but I feel like you need this for everybody in the US, because this system is really complicated, not just for migrants.
Incredible. We're getting a lot of questions from the audience, and I want to turn to that as quickly as possible. I had a bit of a pivot, but it is really all related. There is increasing evidence in the literature that the way we treat people, the way we diagnose people, even the way we develop new drugs and treatments are chock full of implicit biases. They're not necessarily intentional, but they are biases that stem from the way in the communities that tend to be driving some of that research. For example, a recent Nature article showed that efficacy in new drugs so grossly neglects certain population and certain genetic subtypes of the population that there's some real question whether efficacy of a new drug is actually valid in subpopulations such as, for example, those of Asian descent. We certainly know there's a huge gap between drugs being tested in pediatric populations, huge gap between even men and women. And this is despite, the sophistication of random controls and the sort of clinical trial process. And on the diagnostic side, the evidence is also mounting that there are implicit biases in diagnosis, and that de facto results in denying access of care to certain individual. It is well known, for example, that the chances of a woman being diagnosed with something is significantly diminished if it's in a category of diseases or conditions that are viewed as not being likely to be related to the gender. So, I am curious on your thoughts about, because this really is about how we practice medicine, and what can be done for that. And maybe Mariam, I'm curious on the gender equity side from your perspective, and Ahmed, maybe on the sort of race and ethnicity perspective. How do we actually help the clinical practice develop better sensitivity to the fact that the clinical workflow that we're implementing might not actually be, may actually contain implicit biases? Either one of you.
I think that's yeah, I can start first and start seeing sort of the gender aspect of this. And I think we started touching on this a little bit already. And there's intersectionality between between race and gender as well. But one of the things that we know is that women don't negotiate, for example, or they don't ask questions sometimes. So, and the way the healthcare system is structured, not just here, but sort of around the world, is based on either you do what a doctor tells you to do, or you sort of, cross-examine, cross-question what they're doing. And so, you can say, like, here is a health sheet and I provided you all the information, but are you actually having that conversation? And how do you sort of encourage women to be able to ask questions? Because that's something which is often missing in sort of healthcare. Some other ways, I think, because I work more on the sort of health systems perspective and the actual sort of clinical service delivery side, is when you think about access to healthcare and even in terms of like what times health facilities are open, or what kind of job somebody might be doing. I remember when you were doing immunization work in Pakistan, one of the key challenges that we saw in urban poor communities where there were huge numbers of underimmunized children and zero-dose children was that the health facilities were all open their regular times, 8 to 4 or something. But people weren't coming. And it was not a question of distance or anything. It was just a question of the men of the house had to go to work during that time, and the women could not go to the health facilities alone without either sort of an adult member of the family or have their husbands present with them. And the solution to that was simple. Once you sort of understand that, you can extend health facility hours to a time where, when the husband is back and they're available on the weekends or later in the evenings, you would just extend the health facility hours to accommodate them. And then you could actually get more women in the healthcare system. Solution is simple, but I think you would have to think about the perspective of the women. And another challenge sometimes that I see is that there's a lot of statistics around sort of how pervasive cell phone usage is in a lot of low-middle income countries, and what a big youth population that there is. And we're not recognizing and realizing that there are disparities within that as well. Yes, there's a lot of cell phone usage, but there's still a lot of sort of restrictions often on women on cell phone users. So if you're using cell phones as your primary method of providing health information, it's a great intervention, might be a great intervention, but you do have to think about what are the hours that a woman have access to it? What kind of information would be okay for her to access on a cell phone, which if a man from the household saw that information would still sort of be okay with that. And to be able to use it for that. So we do have to think about it from that perspective. And then lastly, I think is the financial aspect of this. So women are often health decision makers in health in many households, but do they actually have the money to put behind it? Or if you have to prioritize for healthcare between a girl child and a boy child, who are you going to put money behind? And that goes back to this question of universal health coverage and primary healthcare systems, and how can we actually reduce out-of-pocket costs to enable women and girls to actually get the healthcare.
Any thoughts on your end, Ahmed?
Yeah, I think looking at overall racial and ethnic biases when it comes to healthcare delivery itself, I think that has, we know, human beings, whether consciously or unconsciously, are all biased in certain ways. But at the same time, I think as a healthcare providers, I think there are already documented and research understanding of where Black family versus white family, racial prejudice behaviors, where the provider is taking more time with the white family compared to the Black family, because quote unquote the white family is considered to be nicer and can have more conversations with them. I mean, there is a whole lot of that already that we know exists, and even when you look at from an immigrant perspective, just the way the system is set up, I think a lot of times understanding in itself how the system is set up, where folks are used to, in around the world, where you actually go see the doctor, you actually meet with the provider for some time, and not, currently the way the system is set up here, where you have, MAs and nurses, and then you see the doctor for like 5 minutes, right? That for someone who's being interpreted on might not be able to ask questions to the medical assistant or the nurses, because they have this perception that I'm going to ask this my doctor these questions, right? So they might not be upfront at the beginning of their healthcare treatment process, where it starts when they walk into the clinic or the hospital. And we've had multiple families, and particularly Somali-speaking families, who oftentimes will feel frustrated because they will go into the clinic and the doctor's reading the notes that the MA or the nurse chatted, and that's how he's going to be treating this patient, right? And not having a whole lot of conversation because they've got a very small amount of time. Their time is very precious. They've got a few minutes, and that's how the type of treatment that the patient is going to be getting. And oftentimes that creates that mistrust that builds up after some time because you're not actually asking appropriate questions to this patient, and in turn, you're not giving adequate treatment for this particular patient. And we've had a lot of frustrations, honestly, to a point whereby we had created an actual program through University of Washington School of Residency in one of the neighborhoods in MLK and Othello through the Mercy Housing units before COVID, where we would have the residency program students, medical students would actually visit the and host a clinic type of once a month for a few hours, especially during the peak hours of the day, maybe from 5 to 8 p.m. or sometimes on the weekends, and meet with the families. And this was sort of trying to figure out how do we ensure that well, we know that not every practitioner is going to be culturally competent and as much as anybody else when it comes to different languages, different cultures, but how do we build that cultural humility that you had mentioned early on, that for them to understand that this is the way these communities respond to when it comes to medical interventions. This is what they know about, diabetes and hypertension and cholesterol. You can go into depth with them because now you do have a couple hours to actually have a conversation with them. So I think the point of discussion should start off with the providers, whereby they actually spend some time, especially with new immigrant refugees, communities of color, understanding that the way that they used to receive healthcare is drastically different than here in the United States.
Very, very interesting insight. We are going to switch subject right now and start taking some questions from the audience. And the first question today is from David Sarley at the Gates Foundation. And the question is, there is an emerging health staffing crisis in Washington because of COVID-19. Does this provide an opportunity for immigrants interested in following their clinical vocation? And is there any framework to sort of fast track some of that I added in the last sentence? And this is a question to both of you, either one of you, if you want to address
it. I'm sure Ahmed has a perspective. I think in an ideal situation, I would say that would be great to do. I'm not sure practically that will happen in terms of this licensing and training requirements that there are in the US. So even sort of what Ahmed was talking about, it took so long to pass the legislation, not just to even get them that license, but just so that they can apply for something. And when you've done a health degree in an entire country, you've been a practicing healthcare professional, do you want to sort of come here? And also the education system in the US is very different. Do you want to actually go and do like your step 1, 2, and 3, pass your MLE exams, and then do like a entire residency again? And some people do, and they persevere. I'm not sure most people would do. It's also a very expensive and costly way to do this and follow. So unless there is a way in which we can grant them some sort of a emergency license type thing, I'm not sure we would come to that solution. And I personally do think actually, yes, we should grant them some sort of a licensing agreement where they can have, yes, maybe they cannot do surgery, but maybe they can do some sort of a GP, general physician type work as well. So maybe there's some middle ground to be had over there.
Yeah, I think I second Mariam on this one. I think considering the pandemic, there have been a lot of waivers when it comes to certain healthcare providers. Even as an example, in the pharmacy field, I mean, in the pharmacy world, we've given access to technicians during the COVID to actually vaccinate people during the mass
Firefighters.
Right, and firefighters. What is stopping someone who is a clinician, practiced a healthcare provider, seasoned healthcare provider, to be given this type of waivers during this type of the pandemic that we're currently facing? I would have welcomed that, and even using certain type of stipulations and a thought process where they actually will work under certain providers as a physician assistant, but grant them access and give them that opportunity to be part of the solution right now as we go through this crisis during the pandemic.
Understood. A different question comes from Tanya Barron at the Taran Group. Climate change and its effects, extreme weather, emerging diseases, droughts, wildfires, some would argue even the sort of frequency and emergence of, pandemic potential viruses, have the potential to further exacerbate access to health equity, especially globally. How are your organizations adapting your programs to perhaps address or mitigate the effects of climate change on health equity, especially for the most vulnerable populations? And maybe that's a question for you, Mariam.
Yeah, I can definitely try and go first. I think, unfortunately, in healthcare generally, there has not been that much work related to climate change. There's some work and people are talking about it, which is great to understand and helpful to understand. And some of the countries that have been most impacted by climate change are the same countries where you have very low health outcomes as well. So there's an intersectionality over there. But I think there's this challenge of seeing the long-term impacts of something and trying to solve for short-term challenges as well. So, and every country tries to balance this immediate need versus this long-term thing. So in terms of equity, I think we do see impacts of climate change and how we're impacting it. There is, temperature extremes are one, a lot of flooding in a lot of countries, which results in a lot of internally displaced people who then become either migrants to other countries or who become internally displaced populations who are living in urban poor communities as well. So there's an intersectionality between some of the populations that we are working with and we are talking about. And climate change might be the reason, but you're looking at some of the same populations as well, and why it's happening. So I do think like one of the things to think about is having a multi-sectoral approach and how you solve some of the impacts of climate change, because it's a multi-pronged approach. You not only have to look at what the immediate impacts are in the short-term solutions of, the healthcare needs of refugees and migrants and internally displaced people, or when there are extreme temperature heat waves. In a lot of countries, a lot of people die, and this has been happening over the last couple of years. And there's a short-term solution of like, give people water, et cetera, all of that. But you do need a multi-sectoral approach, because when there are temperature extremes, depending on the job that you're doing, you don't have the luxury to stay at home. You don't have clean drinking water. You don't actually have a place which is a cooling center where you can actually go to. And you have to go to a job, because if you don't go to a job, your family is going to die of hunger and starvation. This is not only a healthcare problem, it is a multi-sector approach that you need to be taking along with sort of city governments and policymakers, as well as labor industries and employment, to actually be solving some of this issue. I also think some of the challenges are related to how we think about how we have siloed health programming. Non-communicable diseases have been on the rise for a very, very long time in the world, but that is one of the most underfunded areas in healthcare. I think, I can't remember the statistics now, but I believe it was like closer to 70% of the health burden is in non-communicable diseases, but actually most of the money that goes into healthcare is still infectious diseases, because you see the impacts of it. But with climate change, there's air pollution, changing climates, et cetera. NCDs are also sort of on the rise. And it's the silent killer, which, it's harder to know is the impacts are long-term. It takes 10 years sometimes for the impacts to show. So I do think there's a shift that needs to happen, and using a more multi-sectoral approach to health to really combat the impacts of climate change.
Yeah, just to add to Mariam there, I think as an organization, while we are very localized, we will do a lot of education here in King County. I think through some of our programmings, we've been able to implement understanding the climate change, particularly now that we're seeing heat waves here in the Pacific Northwest across the country as well. I think there are a lot of conversations within the community trying to understand how that is also having a global impact. So we've got a youth program of 150 kids, 5 to 17 years old, that play soccer, active of soccer. And, some of them are, especially the older boys or girls, are involved with local program that helps them understand what the impact of climate change is. Some of the presentations are even partnering up with the local organizations that do that type of work. But on the other hand, we also know that the impact that it's also having across the sub-Saharan Africa, and particularly, as our work is seeing across, the African continent, particularly people who follow us on our social media platforms, sometimes we do get these videos that are sent over to us from Somalia in certain villages that are going through, significant deforestation, to whereby there are sand dunes just sort of like sucking up into the houses itself. Like, it's just, it feels like one of those, Armageddon type of movies that you see on Hollywood. So for us, it's like talking to and figuring out what are the next steps. How do we connect with the right type of organizations so that we can at least have some conversations with the local folks on the ground to implement some sort of planting trees and other efforts that hopefully will reduce the climate change that is going on significantly over there at this point.
Terrific. I have a question coming from James Pfeiffer from Health Alliance International. How should the global health community most effectively transition its work to local partners? That sort of empowerment you both spoke about, that is part of building trust, and obviously, especially in the developing world.
Yeah,
I realize we could have a whole seminar on just that topic. So maybe sure. if there is a headline tip that you can offer.
Yeah, this is a very interesting topic, and definitely something that we at VillageReach are exploring in terms of what does it mean, and looking at the decolonizing aspects in global health as well, and how do we decolonize global health, and how do we change our structures as well. And part of my doctoral research is based on this as well, and looking at what is the structure of an effective public health organization if we want to move towards decolonizing. I think the short answer is that it's complicated, and I've worked for very, very small organizations when I was working in Pakistan, and now I work in an international NGO. I've also worked as a donor. So there are three different perspectives here as well. The short answer is I doubt things are going to change unless the way donors work change in global health, at least. And the reason is there's, yes, a lot of conversation and momentum to say we want to involve local organizations and we want to do local capacity building, et cetera. And what I realized is there is no definition of what a local organization is. Some donors have very strict requirements in terms of you need to have local registration, you need to have a local board of directors, you need to have local advisors who are based off that nationality, et cetera. And some have very, very loose definition in terms of you just need a registration. And if you operate in any other country, you probably have a registration. So someone described to me once that sometimes they think chemonics can be a local organization as well, which it's different for different donors. The second thing is, having worked in a small organization, it is very, very difficult to follow sort of these compliance requirements that come from some of the big donors. Not only do you need to have like a lot of unrestricted funding to apply for some of these big projects, et cetera, that come in, it's an investment that you're making. But if you do meet it, you go through a lot of compliance and you require a lot of auditing, et cetera, which you might not have the capacity. to be able to manage as a small organization. So, and some donors are willing, very few donors, I should say, though, are willing to do capacity building investments, but some are willing to do capacity building investments. The second thing is, like, if you do want to move from having more local organizations, I think you also need to understand and recognize that the kind of skills that you're looking for, or human resource that you're looking for, is very different based on different education and cultures and communities, etc. You're not going to get the same person, you're not going to get, like, a US person might do a presentation in a certain way, a person from another country might do it in a completely different way. And that's totally okay to do. They're not going to hit all the right numbers that you want to see. And I think that means that you need to change your expectations of what you're looking for. Sometimes people say, oh, we just don't find people in African countries. It's not that you don't find people, it's just that what you're looking for is different. I personally know of so many cases and investments that donors have done with organizations who, they come into a country, and I've seen this in Pakistan as well, where, they come into a country, an organization will come and do like a really nice fancy presentation with them and have all the numbers to show them, and be like, this is my monitoring and evaluation plan. And they will get, be able to secure the multi-million-dollar investment. And they're not going to know about it if they're actually doing the work. Whereas a more community-based local organization that people might be aware of, they don't actually have the time or the numbers or something to show, but they're doing the work, and the community is going to attest to it. So I think you have to have different expectations as donors in terms of what are you looking for, and be willing to do that capacity building investment. But I do think, I think this is great that we're having more and more conversations in this area. I'm doubtful things are going to change in the near future.
I think I want to be a little bit more optimistic.
I'm a cynic, aren't I?
Hopefully we do have enough people who are listening to these presentations and these discussions that they do implement some of the thought process that Mariam has actually indicated. But in order to have a greater global equity, I think some of the things that Mariam has indicated clearly speaks of the usual way of doing things, right? And I think in addition to what Mariam has mentioned, I think funding local organizations appropriately, right? I think the capacity building aspects, what Mariam has mentioned, is significantly important. I think what we often see from what, as an example as well, is big organizations going to, particularly in the African continent, that, where I've been to Kenya and other places, where there is already a budget for, the expatriates that are actually holding the projects here in the West, right? There's a huge 80% of the overhead cost is already utilized by folks who are actually moving those projects overseas. By the time it gets to the local community, I think it's not a whole lot of funding goes to them. And I think that is a way to change the landscape, is to actually give a bulk of the budget to those communities that are actually doing the work. Yes, of course, with expectations to make sure those deliverables are met. But at the same time, don't set those deliverables yourself. Actually have those deliverables and outcomes should be based on the needs of the communities that the resources should go to. Just this year, a year ago, actually, as an organization, we're doing our very first research in Somalia in partnership with Health Alliance International through University of Washington. And when we're doing the budgeting, we actually made sure that whatever we're paying our own healthcare research professionals here in Seattle is we need to budget for the folks who are doing the work on the ground as well. And I think that was a landscape that we utilized to make sure that we're being equitable and fair enough, because they will be on the ground doing the work, right? And I also think, giving a greater access to the research, if it's a particular research, and autonomy to the research itself is very much useful. And considering that those are local experts and they understand the community, they understand the effort of the work that they're doing. But more or less, I think it all comes down to the funding aspect of the philanthropies or the funders that are going to be sharing some of the work in the African continent or the other countries that they'll be serving. So I think it's very important that we need to change the narrative. We need to start to think differently. And in any space we're advocating for that type of work, we need to start giving that voice to those people who oftentimes feel like, I don't think I can advocate for myself because here I am in sub-Saharan Africa and I'm dealing with someone from a large institution in the United States. I don't think they are going to go along with what I'm suggesting because I'm on the receiving end of this type of work. So I think we're just changing the narrative around here.
Yeah, and there's a cultural element to this and how people perceive authority as well. We might have, in Seattle, a lot of organizations have very flat structures, but in a lot of countries, you still sort of follow very hierarchical structures, and so it still seems like you can say that yes, a country office or a partner is equal, but are they really equal unless they can really raise some of these voices and concerns? And I feel like I should have completed my story about that organization in Pakistan who eventually did get that money, multi-million-dollar grants, just because they were able to, do the wine and dine and speak the language that the donor wanted and show them the right numbers. And, I think recently they were investigated for fraud and they were embezzling money within that. So, yes, you do need compliance, but you also need to be able to, a lot of investments are made through networking and who so yes, compliance, et cetera, is important, but you also, again, need people who know those contexts and those countries if you want to operate over there to tell you what is really sort of happening there. So you're using your money wisely and investing in projects and people who would really benefit the work.
Well, the conversation is fascinating. We have a very long list of questions that, unfortunately, because of time, we can't get to. Those that have posed those questions, if you're interested in speaking or in having a response from our speakers, we will pose it to them by email and see if we can get you some additional feedback. This has been a fascinating conversation that I almost feel it's incomplete, and so perhaps in future programming we'll look to sort of add to that. Maybe in the last 5 minutes, 4 minutes now, could each one of you give sort of one closing thought relating to all of these issues that would essentially be a piece of advice to our attendees today? If they left this meeting with one thought, what would you want them to think about or do?
Yeah,
Ahmed,
yeah, absolutely. Thank you, Maurizio, and thank you to everyone that participated in this discussion. I think if there is one thought that I want to give from this panel discussion is that I think we all live in a global society. I think if anyone did not have that perspective, I think COVID-19 has clearly indicated that all of us are in this together, regardless of where you live, what type of social economic status that you are in, and understanding that if you're in a position of power, I think this is the time to reflect. It's the time to figure out how do you ensure that you're using equitable lenses in your decision-making process. I think it's time to shift the narrative that and change the status quo, particularly in what we consider quote unquote third world countries, that they should not be third world countries, but they should be equal countries, and the rest of the world should be able to have access to healthcare and resources as much as anybody else. So I'm hoping that anyone who's watching this video, this panel discussion, and anyone in a position of power should be able to reflect those thought processes as well. Thank you.
Perfect. Thank you, Mariam.
Thanks, Ahmed. Those are very wise words. I think the one thing for me is to think about it in a people-centered healthcare system and put the person in front rather than the program or project that you are doing. And think about the person in terms of what their needs are, what their challenges are, and what do they want and that's how you really think about and consider equity in any of the work that you're doing. And that's what I think hopefully help people move away from continue doing the work that they've been doing, but just now inserting the word equity in what they're doing, but really be thinking about what do they mean by equity. And I want people to, every time now they're thinking about a project or designing a project, to stop and say and think, like, who are they designing this project for? What is that person? And especially in the field of global health, we've typically thought of as that person in this rural community, which is very far off, which is impossible to reach. And I think that has changed, and we need to realize the world has changed. Yes, that person still exists, but then you also have large numbers of urban poor communities. You have large numbers of conflicts. You have large numbers of migrants. And how do you reach them? And so we design our systems for those people. And that's, I think, one thought that I want to leave people with. And the best way to do that is to also have a very diverse group of people that you're working with who can bring that perspective from countries and cultures and communities.
Fantastic. Well, with regret, we have to close out our meeting. I wanted to really thank Mariam and Ahmed for spending this time and really addressing these questions. Your insight, I think, is incredibly valuable, both as a practitioner and as a thought leader in this. Thank you to the audience for joining us. And a quick shout out to all of you. Please, we're coming up on our Global Health Impact Awards on October 14th. 7 p.m. It's a virtual event, but it will celebrate the giants of global health for this year. And I would love to see all of you attending. You'll find more information on our website and on the chat link. Thank you again for your time, and we look forward to doing more of this in subsequent events.